Okay, I'm going to go ahead and get started. Welcome to this afternoon's session, All in the Family, Strengthening the Medicaid and Public Health Bond for Positive Disruption. Today, we're going to talk a little bit about recent initiatives to strengthen the relationship between Medicaid and public health. Our presentation today is going to include private sector efforts to harmonize and integrate disparate data systems. It's also going to include some information from the CDC on their vision and strategy for public health data modernization. And finally, we're going to hear from the state of Washington, which has an incredibly promising example demonstrating the importance of collaboration between Medicaid and public health. And I'm joined today by four of my colleagues, the first of which is Jeremy Racine. He's the Senior Director for Government Healthcare with Innovaccer. Abigail Vile, Senior Advisor with the CDC, Sean Roberts with the State of Washington, Program Manager for Medicaid Investments, and Chris Baumgartner, who's the Deputy Chief Informatics Officer for the State of Washington as well. I'm thrilled to be here with all of you. I'm going to start here with Jeremy, who's going to talk a little bit about private sector efforts to integrate data from different sources.
Perfect. Thank you so much, Jamie. We're going to keep it flowing here, and we'll have some time at the end for some Q&A, so we've structured all that in. I want to start by just talking about kind of the macro level scale of what we're talking about. 2.3 zettabytes of data in healthcare across the globe by 2020 was an estimate. For folks who are not familiar with what that might be, that's actually 2,300 exabytes. I'd like to get geeky here. Think of it like this. There's a good description. If a gigabyte were Earth, then an exabyte is the sun. So when you're thinking about 2.3 zettabytes, that is, it's billions, right? So it's a lot of data. Obviously, this is globally, so this is not just for the U.S. So I want to talk about the U.S. just a little bit as well. And looking at that, just a small slice, 22 to 26 petabytes of clinical and imaging data, and that's just in the U.S. and that's just one basically data source, right? So think about all the stuff we're working on in Medicaid and public health, a tremendous amount of data coming in, and it is massive, right? I think I'm just setting the stage because I guess when folks, you're working on things so often, you might not see exactly what the breadth of the problem is across the entire US or globe. But anyways, long story short there, right? A ton of data coming in, a lot of systems. Obviously on the vendor side, there's a lot of folks working on this particular problem, right? So question is, Medicaid and public health, are they keeping pace with what we're seeing out there in terms of growth? So this is a very, very, I couldn't think of a better way to kind of like actually capture all of this. So you may have to take a picture or watch the recording afterwards. But let me lay some of this out here, right? I mean, and there's a lot here because we need to look at how things have kind of originated. On the top, we're looking at general technology trends over the last 5 decades. Right, so these are major initiatives, whether it be HIPAA or high tech or other types of HL7, right? A variety of different, what I'll say, general healthcare technology trends, right? And on the bottom, you'll see some that are specific to public health, which are highlighted in purple, and those are trends and initiatives that have driven this growth over time, as well as with Medicaid highlighted in blue. So you'll see a lot of familiarity in there, right? I'm not going to get all the different acronyms on the public health side, but we all know it's a lot, and CDC will talk about this a little bit more. And on the Medicaid side, again, I had to start some of that growth in the 90s because anybody who's familiar with MSIS knows it didn't start until the 90s, right? So, and let me just add in a little side note because I know there's some folks out here, me included, that would say, why haven't you included the mainframes up here from the 60s? And there are some states, I won't name them, that are still using it, and the CDC that's still using them. But hey, Old Faithful, I get it. But for this would have made this effort a lot longer, so I just wanted to kind of focus on areas that are a little bit more contemporary. Anyways, the last areas here, which kind of I think demonstrate this problem that we're looking at, is those vertical arrows. They represent the estimated data growth in each of the sectors. So purple representing the public health data growth, the growth on Medicaid side in blue over that time. And then the last piece of this equation is those lines that are going horizontally and up. And the very top line, which is probably not even that representative of general healthcare technology, should be really going through the roof, right? Because it has taken off at light speed. And you can see the trajectory estimated by Medicaid and public health in terms of keeping pace with this, right? So what's the net of this slide? Well, obviously, we can see that data growth and system growth is accelerating at light speed, and there is a tremendous amount of innovation that is occurring out there, and some of which we are all taking advantage of. But of course, I would question, is there more that we can do? All right, so the net of that slide for today, if we take everything we're looking at and look at what we're actually creating, we have what I nicknamed it Silo City, and it's probably aptly named. So I've got everything you can probably imagine on there, from health information systems that you'd find on the provider side to the payer side, to things from state, local, federal, public health, and Medicaid and everywhere in between. I call it Silo City because, you'll get to this in a second, but it's just a bunch of roads that are very complex, and tell me if this doesn't kind of, maybe bring trauma to some people, but, for me as a data engineer for a long time, it does. But over time, this is what we've created, right? A lot of different roads, a lot of roads built with different standards, a lot of roads to nowhere, a lot of broken roads. It sounds like the city I'm from, like Boston. But the reality is this is kind of what we've created. And obviously there's different variants of it. And I say, if we look at the vendor pool and the people that are supporting some of what's going on here, we have this particular slide, right? So, and this is not capturing every particular point solution that's out there, right? But when you look at everything that you could possibly be doing in terms of the healthcare sector, both on the public health side and on the Medicaid side and in the private side, right? There is a tremendous amount of innovation going on, like I said, all around that type, right? Whether it's looking at care management or case management or EMR writebacks or population health management, there's a tremendous amount. And you all know them because probably everybody in here is has worked with one of these vendors or has had experience with them, or these processes in general might be homegrown. So anyways, the thing is this where it kind of gets into the innovator, because where we sit, as you can see right there, is in the middle, and it didn't come easy. It came by way of a lot of the hard work and some of the silo and the chaotic nature that's happened over the years, right? And we looked at all of that because we did have a little bit of a head start, right? We started in 2015, so we've had the opportunity to look at some of the chaos that was created out here and say, you know what? We see what's going on out here. Is there an opportunity for us to maybe create harmony out of chaos and figure out a way in which we might be able to unify across all those different silos? And so could we look at all of the data that's coming in from all those different silos, whether it's coming from public health or non-public health or clinical or non-clinical, right? All the different sets that it could be coming in from. How can we bring all that together and kind of harmonize it, bring it through, and then how could we make it actionable in a variety of different ways, right? Not just analytics, but actual point solutions that could help with supporting some of this work, both in public health, as you can see, public health specific areas down at the bottom, so whether it be disease surveillance or case management, and then specific to Medicaid on the top, care management and cost and VBC. But then where I like to say, this is again, we're going to hear about some of these real world scenarios, but the combination of those in the middle, you'll see a lot of areas that we're already seeing out there where there's shared movement towards, right? So whether it be health equity movements or alert management, things like that, right? And with that, before I hand things over to my colleagues at the federal and state level, I just want to give one example of some of the work that we're doing, right? And so we're working with a large county out in California, and I think it's a really exciting project. Everything you just saw on those last slides, a lot of that kind of being captured here. They're trying to build a very holistic case management system, and it's driven mostly by public health, but it's being funded not just from public health, but also from the Medicaid side of the house, and looking at taking a more holistic view of citizens in the county. And there are something like 25, 30 different data sources that we're looking to bring in from a variety of different systems, and be able to build this kind of this really holistic view of our citizens. And again, one example being that, hey, if you've got, just as an example, a pregnant Medicaid beneficiary and they qualify for a variety of different services, do you have transparency into all the different services and programs they qualify for? And even if you do you know what the perfect blend is to provide the most optimal outcome? And the last piece of that would be, how are you measuring those outcomes clinically over time? And I would say this type of project is exactly one of the many answers that could put us on that path. So with that, I'm going to pause, and I want to hand things over to Abby from the CDC.
Hello. Thank you, Jeremy. So let's see if I can figure out how to work this. There we go. So I'm very pleased to be joining you today. I know that this conference is very much focused on Medicaid, but as you can see in some of Jeremy's slides, we face challenges that are shared on the public health and Medicaid side. In fact, public health is running from behind. Even with all those arrows going up during the pandemic, we were still far, far below the pace of change and pretty much everyone else. And this is not new. The pandemic highlighted what people in public health have already known for a long time, which is that we have kind of been left behind a little bit on the modernization journey, and that has real implications for the entire ecosystem that we interact with, including Medicaid programs and providers. So we're talking a little bit today about what CDC and our public health partners are doing to redress that issue. And I wanted to start by just kind of noting that one of the things that Mandy Cohen has been sort of, pounding the table about is, and I'm going to quote her here, and I have my little pad in here so I don't get it wrong, but data are the oxygen that power our ability to detect and respond to health threats. That is really what we're doing when we're talking about data and data modernization. It's not just because we need pipes that work, but it's working for a purpose. We need data to actually respond. And right now, I would say that we are all sort of suffocating more than we need to be in terms of that having data that move like oxygen. Obviously, we don't want it to move willy-nilly, but right now, it doesn't move very well at all, and not without incredible effort on the part of everyone to just move it a little bit. In fact, a colleague at ARPA-H has kind of described how public health and frankly research and others operate as we like to build shiny silos, and then we like to connect them with tiny little shiny straws. And we will keep doing that till we build an entire silo city connected by straws. And no one would architect a system that way if we were starting from scratch. But we start with that and we keep building on it. We keep doing the same thing, and maybe we add some bells and whistles, but we're still in the silos and straws sort of approach. And this is not a time to say, what would something other than silos and straws look like? And I think from both a policy and technology perspective, we are at a point where we can kind of say, are there core building blocks that allow us to meet multiple use cases without standing up separate systems for each and every use case? And the answer, we believe at CDC, is yes. Those are starting to emerge, whether it's TEFCA, FHIR, or USCDI, and these building blocks present us with an opportunity to really rationalize, get our public health house on a more sustainable footing, both financially and operationally, and they allow for alignment with other sectors, because public health has been operating in one place, Medicaid in another, providers in another, and again, connecting with straws, and we don't want to be there. So on that alignment piece, at CDC, we're thinking not just one CDC or even one public health, but we really need to take what we're calling a public health ecosystem approach. And fundamentally, that ecosystem approach means understanding what our partners are doing and making sure that we're finding places to align. Again, we don't want to build in parallel. We want to say, how might we leverage one another's investments in a more rationalized way that means fewer systems, less friction, more efficiency. And in particular, some of the principles that we are thinking about as we take this modernization journey in public health are collect data once and reuse it wherever possible. Don't make people report the same data to 5 different systems and 10 different users. Automate data collection and analytics to improve access, insights, and action, and connect public health with our ecosystem partners. Healthcare in particular is one of those, and healthcare includes both provider and payers. So really, again, not operating in a silo. And when I say connect, I also want to emphasize that what connection means needs to fundamentally change too. You could say public health and healthcare are connected right now, but if that connection is facilitated by faxes, it's a pretty painful connection. And then when you amplify that across all of the different points of connection, it becomes a ton of friction. So when we talk about connect, we're talking about connections that reduce burden, reduce the friction of data exchange, enable more effective communication, because effective communication means coordinated action, and advance faster insights. And to do that, this is a journey. It's a marathon, not a sprint, to pull out one of many cliches I will probably bedevil you all with at some point during this conversation. But we need a plan to get there, because we can't just change overnight. This is something that we need to plan towards and then walk in sort of a ongoing fashion. So one of the things that we have published recently, and then published in 2023 and then updated recently, is CDC's public health data strategy. And that data strategy is both a blueprint for how we are it's a blueprint for how we are going to modernize people, processes, and technologies within public health. It's also a blueprint for accountability. It tells you exactly what our goals are for each milestone that we've identified for 2024 and 2025. So we're saying, hey, look, we're not just setting milestones, we're publishing them, and we are asking everyone, our partners, our stakeholders, to hold us accountable. We won't always reach everything, but we want to continue to press forward, and we want to do that in a very visible way so that people know where CDC is going, know where public health is going, and why. And we are actually making progress. So this is a good example of what has changed even in the last 4 years. This is electronic case reporting. For those who are not familiar with case reporting, it's sort of bread and butter for public health. It is how we learn about new infections. It is how we detect outbreaks. It powers outbreak responses. It is a core and fundamental activity in public health. And prior to the COVID pandemic, less than 200 healthcare facilities were able to send electronic case reports. It means everyone else was basically using faxes. Now, we still have a lot of folks basically using faxes right now, but in the last 4 years, we have gone from less than 200 healthcare facilities to over 38,000. And faster reports means faster detection, it means faster response, it means less spread of infectious diseases, it means getting people the services they need faster, it means a faster response. It also means, importantly, not having to do all of that paperwork pushing that just, again, administrative friction. So electronic case reporting is one of the core, areas where we see a ton of promise, and we are seeing people get on board. We still have a lot to do, and if you're on the western side of the United States, we need to work with you a little bit more, but this is a really important and, sort of milestone that we like to hold up and say, this is where we're going. We've made a lot of progress. We've still got more to go. Similarly, and I'm going to use this moment to plug an upcoming talk later today by Chris. Public health is really leaning in on TEFCA. Another point of friction and challenges for public health is that we have to point-to-point connections, sending data to this person and sending data to that person, or receiving data from different providers. It's just extra work on the public health side, and frankly for providers as well. So TEFCA sort of provides a way to sort of create a glide path where connect once, and reach multiple providers. That's really attractive for public health. And so we have been sort of pushing for public health to be at the front, at the front of the pack in terms of TEFCA adoption. And we are proud to say that, on July 1st, 2 public health use cases within the TEFCA sort of architecture went live. And you can hear more about one of those use cases from our state partners here from Washington, because they have helped lead the charge for electronic case reporting via TEFCA. The other part had to do with query, and we had 3 jurisdictions, Maryland, Alaska, and Fairfax County, Virginia, that had been part of that. But we see TEFCA as an opportunity to, again, just reduce that friction and use infrastructure in new ways that allows us to, retire some of our current business practices within public health. So, at the risk of mixing metaphors, because we are supposed to be talking about all being in the family right now, but I'm going to go and take a hard left and say, protecting health is a team sport. But it is important to say, CDC, public health, we can't do this alone. We are part of that ecosystem. And I recognize also that this ecosystem is very much crafted from a CDC perspective, so you guys would probably name it something different and have different nodes on here. But the concept makes sense. It's that we are all working in one ecosystem. And if you imagine like a soccer team, if everyone brought their own ball, it would be interesting. But it wouldn't be a very effective game because you couldn't actually have a game. You just get to dribble around and look at one another. It's not actually working as a team, and that's what we ultimately need, whether it's around data or other pieces. And so one of the things that I see as one of the more exciting opportunities, and I think our Washington folks are going to tell you momentarily how we can operationalize it, is for Medicaid and public health agencies to say, okay, we're all trying to modernize. We're all looking at some of these similar building blocks. We can do these things in parallel. We have done things in parallel for decades. No change. There wouldn't be a change of operation there, but we need not do that. And we may be able to get more efficiency, more bang for the buck by working together and saying, what are we trying to accomplish? And where there are places where we're trying to accomplish similar or same things, let's think about a different way of working together, leveraging one another's capabilities, assets, and authorities to say, okay, let's build something that fits multiple use cases as opposed to continuing to erect silos in our silo city. And with that, I am going to turn it over to my colleagues in Washington to talk about how you might actually do that.
That's perfect. I'll get us started. We're going to talk a little bit about kind of our journey, and I want to thank both Jeremy and Abby for kind of providing some landscape pictures. Starting at like a 50,000 foot level, Chris and I hope to bring it down at the state level to about 10,000 feet. So what does that look like for a public health agency? And being in this audience and talking with this audience, I want to respect many of you probably don't work for a public health agency, don't understand our perspectives. And Chris and I's goal here is just to provide a public health perspective to how do we support Medicaid and how we as a public health agency need to look towards Medicaid. One thing I'll say right off the top is we have amazing partners in our state. We are not the Medicaid agency. Our state is broken up of, I think it's 5 or 6 health agencies. And our state Medicaid agency is our healthcare authority partners who have been instrumental to our work. And they're the ones that actually paved the pathway for us to walk. They're teaching us along the way and helping us to navigate this. But there's a responsibility we have as public health to educate them too of this is the work we do. This is the impact we think we're making with Medicaid. Does this make sense? So one of the questions you might be asking is why should public health even consider Medicaid from the standpoint of a funding model piece? Traditionally, public health, we work on a grant-based system. Over 70% of our yearly budget, most of the time, is grant funding. Now, this is not grant that's continual year in, year out. We always have it. Actually, we have to reapply on a regular basis. Some of our grants are a year long. Some of them, good ones, will be a 5-year cooperative agreement. But anytime within that agreement, we can get a notice from our partners at CDC is that funding's being reduced. You need to change your budgets. Funding's going away. This happens on a regular basis. I wish it didn't.
We do too.
And a lot of it's because of the federal budget. Depends on how much grants we have. And then they can redirect funding at any point. That is a big deal we have to do is we'll say we're going to do these activities. We're going to build these systems. We're going to have this much capability. And they'll say, actually, we don't want to do that anymore. This new disease popped up. You need to respond to that. Use the dollars over there. And we're not going to replace the dollars you lose. So we live in that constant world. We also live in a constant world of constant crisis. COVID is a great example because it impacted a lot more. But on a day-to-day basis, it could be something new. I remember years ago, I worked emergency preparedness and response for public health for 14 years of my career. We called it the disease of the month syndrome. But we'd get new funding saying, hey, go respond to Ebola. Here's new funding, go respond to Zika. And you're building one-time things, one-time effort, and you hope that you have money down the road to keep those systems operational. Many of public health agencies do not have sustainable funding. Many years ago, states started to move away from sustainable funding for public health. I know in our agency, we had taxes that would be collected that paid for this. Those were nixed through a voter initiative. And we've had to learn how do we become more sustainable in a world that we can't count on funding. And for us to really to know to move forward and to do what CDC's asking us to do, what Medicaid's asking public health to do, For us to move in an environment that's more sustainable when we talk about DMI, we have to start diversifying our funding. We do not look at Medicaid as a primary funder in the sense of, oh, this is going to be the windfall that saves our lives. That's not the way a public health agency should ever look towards Medicaid. This is a part of a solution, it's a piece to it. It is not the whole piece. And a public health agency needs to have a strategy on how do we fund an effort using multiple different fundings, multiple different requirements. That's one thing we're very lucky in our state to have partners that will coach us along. Hey, this is what's reasonable to expect. Don't expect more than this. But each state needs to be able to have that conversation with their public health agency because we are looking for that gold at the end of the rainbow. I'll be honest, we are in public health. We're always doing that. But having a reasonable expectation is important. And finally, CMS, looking at sustainable funding from CMS, there's a couple of things that are a huge benefit to us. Traditionally, public health, we build things based on time. We have the funding for this long. We got to build it quick, as fast as we can. And we may not always think of standards up front. We think of standards as we're building. As the plane is on the strip getting ready to take off, we're building it. So standards kind of go as we go. But with CMS, we have to put more thought into it. We have to follow reuse standards, which for us is a great thing in public health, makes things more sustainable. The standards like certification are a big deal for us because it helps us to build a system that's more integrated. Modularity is huge. This is something CDC, others are asking us to move more towards. Instead of having these individual siloed systems on what I call islands of excellence, is how do we start to develop systems that are more modular, integrated from the very beginning, and not trying to do, like, as she said, the connected straws as an afterthought. But to kind of begin this conversation, we had to, as an agency, look at our landscape and our ecosystem of systems. So I'm going to transfer over to Chris, and he's going to kind of talk about what does that look like.
Maybe. Okay. Don't focus so much on the funding picture in the middle. COVID has made it a mess to try to redo that with updated biennial numbers, but really look at the outside of this circle. This is just a taste of the things that our public health agency does for the entire state of Washington on a regular basis, and it is amazingly diverse. We're also a very unique public health agency because we actually do all the healthcare facility and professional licensing in our state, which also, as you can imagine, is a benefit to Medicaid, right? Because the Medicaid agency is going to want healthcare professionals that are actually licensed to practice medicine or nursing. They care about that, and so do we. And so just taking a look at this, Sean already talked about emergency preparedness. How many of you like to drink safe water every day? I do. How many of you like to know that the food you're eating is safe and that restaurants and things are being inspected? And that's just a taste at the top. Around the side here, another big piece that ties into Medicaid and what public health benefits is the WIC program, Women, Infant, and Children. We provide a lot of nutritional services to Medicaid population folks. Maternal and child health. We do a ton in chronic disease management. You want to talk about the number one problem around morbidity and mortality? It's not COVID or other infectious disease. It's hypertension. It's diabetes. It is chronic disease. And as we learned during COVID, the people that had the worst outcomes for COVID had underlying chronic disease conditions. If you can't breathe well already, COVID is not going to be good for you. And then you look at some of these other things as well. We have a public health lab. A lot of testing for really important things go to one place, and that is our public health lab in Shoreline, Washington. We also do newborn screening at that lab for every single birth in the entire state of Washington. Again, another big benefit to Medicaid. They care about making sure if there's something that we can detect early in those little kiddos, and can treat right away, that's important. We also do a ton in injury and violence prevention. I'm going to talk in a minute about some specific systems in that area, like prescription drug monitoring, and the list goes on. But as you can see, this is just a taste of what most public health agencies do. And I'd like to think you could see, there's a lot of things on this list that are hugely important to our Medicaid partners and benefits that we bring to the table. So 2 highlighted examples just to drive it home a little bit more. One is prescription drug monitoring program. For those of you not familiar, it basically collects controlled substance prescriptions from pharmacies and other dispensers and then primarily provides that data back to healthcare providers so they can make better informed treatment decisions in attempts to address the opioid epidemic, as well as other concerns around use of controlled substances. And so, at least in our state, we are able to provide that data directly to the Medicaid program. And that's really important. The Medicaid program has requirements under the Support Act to report certain pieces to CMS and the federal government. A lot of that data has to come from the state's prescription drug monitoring program. Also, there's the benefit to Medicaid providers. Again, Medicaid under that Support Act required providers to check the prescription drug monitoring program before they issue prescriptions for controlled substances. So if the PDMP doesn't exist, they cannot meet that requirement. And while not all PDMPs are run by public health agencies, quite a few of them are. I think about almost half, or maybe a third of them are. And so that's a big benefit. And then also you think about the benefit to the Medicaid client. We're helping identify potential overprescribing, opioid use disorder, or even interactions that are dangerous between medications. And that's a benefit to the Medicaid client, hopefully preventing adverse outcomes from their use of controlled substances. The immunization registry is kind of another kind of clear-cut, easy one to look at when you think about benefit to Medicaid. So again, this purpose is kind of twofold. One, we collect all the vaccines administered by all the providers in the state, so we have a registry of all those vaccines that have been given. And you can imagine that's incredibly important if you're now a provider and you have a new patient and you're like, well, I don't want to give this person the same immunizations they've already received. And the query to the immunization registry does two important things for the provider. It not only gives them the history of all the immunizations provided, it actually gives them a forecast, which is really cool. Like, here are the upcoming immunizations this person's going to need. And so as you can imagine, that is very beneficial because Medicaid has some requirements around making sure that their clients are receiving proper vaccines, especially kiddos. That's hugely important. And then again, huge benefit to the Medicaid provider who's treating those patients. They can query this directly from their electronic health record system within workflow. It's integrated using HL7 messaging through our HIE. They don't have to get out of their workflow, log into a separate web portal to view this. And that's obviously a huge benefit to the Medicaid client as well, because we actually also have a way that they can go and receive their own immunization history from our system as an individual or for their kids. Who's had to enroll their kids in school for the fall? Guess what you need? Their immunization history. And so again, this is another system that provides, I think, really clear benefit to the Medicaid program, the Medicaid providers, and Medicaid clients. Another thing we wanted to highlight a little bit is, Sean mentioned that our Health and Human Services are spread over several different agencies in our state. And we've been working collaboratively with the Healthcare Authority and those other partners across what we call the HHS Coalition on a number of projects. And that's another really exciting opportunity for public health, we believe, to partner not only with Medicaid, but other Health and Human Services agencies around important things like reuse and really trying to get better bang for our buck collectively and better serve, ultimately, the most important thing, the residents of our state. And so just one example is we actually have a shared master person index across the whole coalition. And that's really exciting for a number of potential opportunities. Not only does it allow a public health agency, as Sean pointed out, who doesn't necessarily have a lot of money, to be able to leverage a really powerful MPI, but it also allows us to do better linking to Medicare data to look for better cost allocation strategies, assisting us in deduplicating our data sets and providing better data to Medicaid. Data enrichment option comes with ours, where we can look for missing demographic or contact information, which is really important. We had, I don't know how many percentage of our labs, especially early in COVID, where it would come in with no contact information. It's really hard to do case investigation if you don't know how to get a hold of someone. And it's really important because you don't want them to spread the disease. And also, it's just been a really interesting project to think about too, how we can leverage it for our own internal work to de-silo our systems. We talked about all these different disparate systems. I will ashamedly admit we have over 50 surveillance systems in the Washington State Department of Health. And being able to link them together more easily for important things like how many people died of this specific disease becomes really important. And an MPI is really helpful for that. And with that, I'm going to turn it back to Sean.
Thank you, Chris. Last couple slides, I just want to provide some considerations and some things to think about as you engage with your public health partners, if you're from the Medicaid side or if you're a public health agency yourself. What are some things to think about? I come at this from kind of a unique standpoint because in 2020, we are all responding to COVID, as was I. I got one day, we called it off the response team, and I walked into my boss at the time, who is our CFO, and she said, hey, I got something new for you to do. I want you to take on. And I'm like, awesome, what is it? Medicaid. We need to learn it. And I need you to work with our healthcare partners and kind of help our agency navigate this. And I navigate it from really a financial standpoint. What I'm finding, though, is the financial standpoint isn't the priority. The priority is the partnership. And the one thing I know I stressed before, I'm going to stress it again, our state Medicaid agency is integral to the work we do around Medicaid, not just us getting to funding, but us understanding our impact. They see it from a Medicaid lens, and they can say, hey, I understand you're coming at this from public health, but here's the value we see from Medicaid, and you can help to explain it that way. So one of the things I would say about this a little bit is in public health, we have to learn a new language, a new audience. We're not changing the work we do. We just have to speak to an audience in a different way than we're normally used to, because we talk about population health and population impact. Medicaid's worried about the Medicaid population, and how does it help to support kind of three different groups when you talk about Medicaid? The state Medicaid agency, what's it doing strategically to support them, and how does it support them be the Medicaid administrator? Two, the Medicaid provider, how does it support them? Does it save time for them? Does it make it easier for them? Does it make it easier for them to provide care? And then finally, the patient. A couple of things from a public health agency we have to consider is Medicaid requirements are very different than from our requirements at CDC. Looking at different ways to measure success, different ways to build things. Medicaid only provides funding for the Medicaid benefit level, and this is hard for public health to digest a little bit. Most of you folks in Medicaid understand this even better than we do, but we have to come to the table knowing that Medicaid's only going to pay for a portion of it, and that portion still means the whole project has to have the requirements. We have to understand that there's going to be a process to allocate. We're not used to this. We're not used to breaking out populations and what is that benefit to that population specifically. That's something we have to learn. And close coordination with the state Medicaid agency. We can't just jump out there and do what we know needs to be done. We need to coordinate first. We need to get on the same page, have good expectations, make sure we have those expectations conversations. Each system will have to have clear Medicaid outcomes and metrics. We in public health are very used to measuring our impact. It's not foreign to us. What's foreign to us, breaking out the population the way the Medicaid would like to see it. How do we actually influence and make a specific change on Medicaid? And how do we look at strategically the Medicaid outcomes from an impact of, hey, there's a Medicaid strategy, there's process and procedures there's policy, there's state objectives. How do we tie that there? And then through our data, tie metrics to that. And then many public health agencies are already providing support. Many of you already probably got data coming from immunization records because you have reports that are doing. A lot of times we're doing the work. One thing I've been in public health for 20 years. One of the reasons I love it is we're always willing to go to the table and do everything we can. But at the same point, we have to think of that sustainable mindset of how do we get to a place it can be sustainable long term. Some challenges for public health to be aware of, and I speak at this from a public health agency so that you, if you're in a Medicaid agency, understand what's challenging for us in public health. One of the things is certification's a big challenge for us. Most of the time when we're developing systems, we're thinking about time and efficiency. We have a very short window of funding available. We have a very short window to get it tested and working. And we have partners on the other end that are counting on us to be successful. And we want to go live as quickly as we can in an effective manner. We're not always thinking of, hey, we have all these requirements that we have to maintain and take the time to do it, because many times we don't have the time to do it. So it's a change of perspective for us to say, wait, we need to slow down. We need to make sure all these requirements are there, including like 508 compliance. The penetration test is a big one, and being able to demonstrate our system effectiveness before it goes live. That's new to us. Many times we're sitting with the vendor doing vendor days where we're getting everything ready to go live. We're working with partners on the other end to go live, but this is new to us. We've had to look at laws because some of our laws do not allow us to demonstrate systems to non-public health partners. So we have to navigate that. Finding state match is very difficult for public health agencies. We don't have a lot of discretionary funds that are state dollars that can be used for match. So we have to think ahead of that, and I do a lot of this work working with our legislator to try to get match dollars so that as we partner with our healthcare authority, we're ready to provide that match once we get approved for Medicaid funding. And then balancing different requirements from different funding sources. I think we're all in this boat because we're not all single funded most of the time, but in public health, you might have one project that has 7 different funding sources just to get that project off the ground, with 7 different audiences asking for 7 different requirements. So it can impact project timelines and the dynamics around that. So it's something for public health to be aware of and to do some education to make sure we're ready. And with that, I think we've provided the details. We're going to open it up.
Yeah, I'd be happy to kick us off with some questions, and then we'll make sure that we leave time for you all in the audience to ask questions as well. Chris and Sean, just so appreciate that wonderful example of collaboration and your commitment to working with your state Medicaid agency to ensure that you're sharing data in a way that's productive for the citizens of the state, right? And thank you also for detailing some of the challenges. I had the honor and privilege of serving as a Medicaid director in a couple of states, and I understand how important that partnership is with our sister state agencies, particularly in emergent times, whether for me in Texas, it was Hurricane Harvey, in Arizona, it was COVID, but also understand the importance in emergent and non-emergent times of partnering with private sector entities as well. So I'm just going to kick us off with a question around how can we partner with both public sector, sister state agencies, and private sector parties to align efforts to promote data sharing and integration. I don't, Jeremy, if you want to kind of kick us off.
Sure. I mean, we'll use that for the audience in a second. And I think it's an excellent question. And at first, again, I want to thank my colleagues here, Abby and Sean and Chris, for all the time you took to go through everything you've gone through, and so I can't thank you enough. So I just wanted to put that out there. The question about improving collaboration, and I think Washington, CDC is doing great work with this, but Washington, you just showed like the coalition is an excellent example of that. I mean, I think that should use that as a model, because I think that there should be more of those types of initiatives going on across across the states, even at local levels. I just think there could be more collaboration in general, and maybe not even, and I don't know enough about the Washington example, but there should be a private-public partnership there, right? I mean, we all have feedback, we all have smart folks on both sides who care very much about these initiatives, so the more we can collaborate there, I think it's going to really lead to incredible outcomes. The last piece I'll say as well is, we have to be more thoughtful about, hey, I put all that stuff up in there because I don't believe technology is necessarily the problem right now. I think there are policy issues, there are bridging the gap between legislative side and program side, and I think a lot of that is education, enablement, training, getting folks out there to be excited and knowledgeable about the power of data and analytics, and I think if we can do that, we can see some movement in those areas.
So I'm gonna build on your response really quickly. I know, Sean, you talked a little bit about sort of some of the policy and regulatory barriers to collaboration. Abigail, Sean, Chris, others, I don't know if you want to expand upon that.
She name-checked me, so I'll start. One of the things I think we do a disservice of, especially, and I'll speak from the public health standpoint and speaking as a state of Washington, what lessons learned we have. Sometimes we get so excited about the action, we don't ask the questions. And I think sometimes taking a moment to ask some questions, especially when it talks about collaboration, of what other partner agencies does this impact? And what is the feedback I need from them before I can move forward? If we don't do that, we usually jump ahead, and by the time we're ahead a little bit, for a state, it comes to a legislative ask, and then our central office of financial management will start asking questions. Did you reach out to the healthcare authority? Did you reach out to this group? Well, we didn't necessarily have time. We thought this, and it can slow things down. I think early on asking those questions of who do I need to collaborate with, how does it impact them, and how do I engage them quickly is really, really important to begin that process. Because I think sometimes we can get so laser focused on the problem and that there's a solution that we forget there's people and organizations involved that need to be a part of that. And many times we fix what we think is the problem, but we didn't engage the right people, and there's a bigger problem than we anticipated. So I think doing that is important. When it comes to kind of the policies and procedures, I think that collaboration is so important. One of the things that Chris taught me early on, because he started this work before I was brought in, and him and I have been partnering ever since, working with Healthcare Authority, is we've got to ask the right kind of question to our partners to understand what policies and procedures we don't know of need to inform this work. That's where our healthcare coalition is so important. If you don't have something at the state level, I'd highly recommend creating some way to collaborate on those conversations, because it helps you to inform your solutions in a better way. And if you can think of them early, it opens up better doors of collaboration to find the best solution. Does it slow things down a little bit? Yeah. Does it make things a little bit more difficult at times because there's more partnerships and more, what I love to say is relationship management? Absolutely. But it's actually the greatest success is when we do that well. It's not actually the IT system. It's when we do the partnership and that relationship management and we do it well and we're effective there, can we provide the greatest benefit to our citizens in our state? So.
And I'd just add, I mean, one of the things that we're learning from the early TEFCA demonstrations, well, when we went into it, I think to Sean's point, and we said, we're going to push all in, and I won't say that this is true for Washington, but one of the things we found generally at the federal level was we didn't do enough to bring providers along. So if you're on one side of an exchange, but the other side is not there, that's a challenge. But we're starting to say now, how do we bring people together? And one of the things, just to build on your point, is one, you have to talk to them, you have to think about bringing them in proactively. Two, getting concrete. When we're in this space and we say things like TEFCA or fire, like it's so big. And then when we talk about national scale change being needed, it feels overwhelming. So one of the things that we're talking about now is how do we build like communities that are ready to go forward? Like, let's demonstrate this in a very sort of geographically targeted way and get it right and show people a path to scale. So getting a little bit more at like pilots, demonstrations before going all in, so that you can test how all the different regs and policies and, you know, nooks and crannies of partnership and relationships, how they will actually operationalize together and how you can fit them to kind of push towards a whole that actually yields value for all. It's sometimes scaling back, to your point, and going slower is the way that we actually ultimately go faster.
Yeah, makes a lot of sense. And I do think sometimes those language and translational issues are bigger than even the policy issues, right? Just how we talk with one another and learning each other's language. So Abigail, I'm gonna ask you to respond to this next question. How can interoperability help address health disparities and improve health outcomes for vulnerable populations? I know that's been a big area of focus and commitment at the CDC.
I mean, it has. You know, we're thinking a lot about this because I think, Chris, to your point, you mentioned that lab data didn't have location information. You know what else it often doesn't have? Race, ethnicity, and other demographic information. And if we can't see what's happening and what populations are most affected, we're kind of flying blind. So, you know, CDC has been working in a couple of different areas. As part of our public health data strategy, we're really leaning in on like improving the flow of standardized demographic and social determinant of health data. That's one of those sort of areas where everyone agrees it's important, but getting those things standardized and then getting standardized elements to start moving around still really far away. The other piece is looking at what the policy architecture looks like and saying where are there gaps that we need to fill. So for example, US CDI is, you know, the United States core data for interoperability is slowly building out and adding more demographic information over time. But there are a lot of elements that we need to do public health effectively that aren't there. So we're coming up with solutions like US CDI Plus, which is this adjunct to US CDI core that says, what other elements do you need to do things well? Let's define those so that people can say, okay, this is the data that are needed for, these are the data needed for public health. And I think that's important when you're talking about a partnership between public health and Medicaid, because the data that we need on the public health side Medicaid needs to. I know that CMS is starting to push for example, stratification of quality measures. You guys are feeling the same pain as we are. Like if the data don't have the information you need to stratify, you can't tell if performance is variable across populations. So these are places where we're doing a lot on the CDC side, but it's not enough to do it just in public health. We have the same data needs across the landscape. And so this is a great place where alignment between public health and healthcare just makes sense.
Yep, absolutely.
Yeah, and one thing I'll say with that too is this is a really good example for public health agency is that we do engagement, asking our partners of, hey, what's important from you in this system and this data collection? Because we're updating it. We're going to do something new. This came up in COVID a couple of times because different federal partners were asking state agencies for certain data to be reported to them. Well, public health was collecting the data. The problem is if we're not collecting the right data that you need to digest to do your reporting, you're either going to have to find some new way to collect it, which could be manual. It could be, hey, grab a spreadsheet. We're going to start making phone calls, which we do that great in public health, by the way. Or it could be, hey, public health, could you modify this surveillance system to capture this unique identifier? That's something we should be at the table talking about. Because if we can deduplicate work and make it streamlined, make it for the person who's doing the reporting, not have to worry about, oh, is this going to state Medicaid? Is this going to public health? I just have to report this once and it's done. That makes it easier on the other end, which I think we have to think about when we're looking at it from a government perspective.
For sure. So we're going to open it up to audience questions. We want to leave a few minutes if you do have any questions for the panelists today.
Start here and then go over here.
Thanks. So I'm Bill McQuaid from Rhode Island Medicaid, and I know I don't look it, but I'm an old man. And I start prior to 1980 on your system, and I just want to make a comment on, as we get bigger data sets, as we get gazillion data points on our data sets, I think we lose our focus on how we define our variables. You know, so when I was in graduate school, we spent a lot of time on primary data sets and how you defined asthma, how you defined heart disease and that kind of stuff. And I just want to make a point or thing. We don't seem to focus on the definition of the data sets that we're looking at. And if you have any comments on how we can comment that would be good.
No, I think that's a great point, and just for a classic example to draw out what Abby talked about as well, is we have a desire in public health to look at prevalence of chronic disease. Well, guess what? So does Medicaid, right? And guess what? So do payers. And so, really looking at, instead of developing separate measures for how we define hypertension, diabetes, asthma, I really like the idea. One thing we're looking at right now actually is reusing the ECR Now app, the electronic case reporting app that is primarily being used now for public health infectious disease, notifiable condition reporting, and modifying that to also allow it to develop the ECQM, the electronic clinical quality measures that Medicaid needs for chronic disease. And if we can repurpose that on the public health side, to Abby's point, then suddenly we're not asking our healthcare partners to send basically the same data in a slightly different flavor to two different agencies for more or less the same purpose. And so I think that's where things like USCDI become so critical, where we get together, and I'm thankful for the leadership CDC and CMS and ONC have been showing in that space of trying to use USCDI as a way to harmonize and try to reduce some of those burdens that we're putting on providers primarily.
Hi, Heidi Wilson. I'm with Connie, Connecticut's Health Information Exchange. You touched a little bit on working with the Health Information Exchange in Washington, and I was wondering if you could talk a little bit more about how that's been helpful or limitations in being a connection point for interoperability.
Yeah, I can't say enough about our Health Information Exchange. They were an amazing partner and still are. Just for context, we did over 200 million transactions as a public health agency last year through our Health Information Exchange across 5 different programs, and we're looking to add even more. It's another great way, to Abby's point, where we do not need, otherwise we would be building and maintaining 400 separate connections just for healthcare systems in our state. And we do not have the budget for that or the staffing for that. And so, yeah, I can't say enough about leveraging things like that. Also excited to see about how HIEs can play a role in TEFCA, perhaps as our on-ramp, as our way to onboard into a QHIN for some of our other use cases.
Good afternoon. Thank you for your presentation. My name is Laura Gustin, and I am an executive director of a community information exchange in New York State. On one hand, we have over nearly 24 states with health-related social needs in their 1115 waiver demonstrations right now. And on the other hand, going upstream feels like a core public health function. So I'm wondering if you could speak a bit more about the opportunity to build social care data and to connect Medicaid and public health around the growth of social care data, and also how we might accelerate that process, because it feels right now in the community information exchange space that we are building silos with straws because there is a lack of good information and standards to do this work.
Yeah, I think at least in Washington State, and maybe you can respond to on the more of the federal level, but that is again another place where our coalition is the right vehicle for that. You know, there's so many agencies across HHS that need that SDOH data, and so that's where we've been partnering with Healthcare Authority, the Department of Social and Health Services, and the other coalition partners on a CIE project, because we recognize that needs to be, you know, a health and human services environment-wide solution. To your point about standards, I think that's a tough one. I know we're trying to do what we can to look at things for like our 988 solution around using things like the e-referral standard that's available, but that means, do our CBOs have the technology to produce those messages? And I think that's another challenge we're going to have to try to address, because the healthcare side is there and getting there. We need to find ways to help our CBOs out, because they're part of this whole person health big time, and we need to find some solutions there.
One last question.
Hi, I'm Shin Yi from New Jersey Medicaid, and my question is about your point about deduplication, but actually potentially leveraging the power of having two overlapping data systems. Like, I'm thinking about some of what you've said about vaccination rates, and I know there are certain things, say, on vital statistics that correlate to maternity care that should also be replicated in Medicaid claim data. And curious to know whether, as part of the collaboration, there has been any active sort of comparison, like, hey, our Medicaid claim says this number of people were vaccinated. Does that match when you actually go into your vaccination data? Because I feel like there's a data accuracy challenge that we're having, and being able to leverage the fact that the data has come through in two different sources could help us like clarify, okay, you know, what are the strengths and weaknesses of the two different data collection methods?
I mean, I can say that certainly we did a little bit of that during COVID. We actually worked, CMS and CDC worked with a couple of states and looked at sort of what was coming in for Medicaid and Medicare individuals and what was in IIS. And what we found is good areas of overlap, and then there were some unique people on both sides. And I think that that's part of a path towards actually getting away. I mean, duplication is still duplication, so that's friction you ultimately want to remove, but having that pathway that begins with saying, well, what do I have? What do you have? What are the strengths that are contributing to the fact that you're getting this piece and I'm getting this piece? Okay, now let's talk about a solution that pulls on those respective strengths, but avoids that middle part where essentially we've just collected things twice. And so what we did find, at least for immunization data, is that, you know, often public health had more demographic information than the Medicaid folks did. And so we were able to share some of those pieces that were missing from the IIS. But there were folks that, for whatever reason, the providers, maybe they weren't required to report this particular vaccination or something like that. It was captured in claims, but it didn't go to the IIS. And so now we're finding, oh, in fact, the actual percentage of vaccinated individuals in this community is X versus, you know, V. I don't know why I'm pulling those letters out, but those are the two that popped into my mind. So I think there is a power there to kind of say what's the quality assurance piece, but then we don't want, and I will confess, I have heard this about public health right now, we don't want quality assurance to be perpetual. And so one of the examples that we hear is as people are moving to electronic case reporting, the public health agencies won't actually turn off the faxes. So we're getting a forward motion, but we're using that quality assurance as a way to say, I can't let go of what I liked to do. And that we don't want to get in that place either. We need to take that quality assurance, figure out what's working, but then transition effectively.
There's one thing I'd like to add to that, just because a new lesson learned I've had in the last 60 days. When it comes really to that, one of the things that's really important, especially from a public health agency and a Medicaid agency, is make sure the right folks are talking about the data between the two agencies. Many times, it'll end up in a contractual agreement between one agency and another is, hey, we'll pay you this if you give us this data. By the time it gets down to the actual data people, it's so miscommunicated is the word I'm going to say, on what data is actually supposed to be collected and shared. The groups don't talk, so they just share information. On one side, they're like, this data doesn't make any sense, but if that's what they want, they'll send it. The other side gets it going, this isn't the data we wanted, but I guess it's what we have. We can easily get caught in that. Most of us work for government or work for larger organizations. We can all get caught into that. What we have to ask is the hard question. Are the right individuals talking to each other to make sure we're sharing the right data? Because we all want to, we all have that desire to, we all have the desire to collect the right data and share it. But time is the enemy of us all, and we all have different partners. And if we're not talking, we could quickly make a bad decision based on what we have as good intentions, and it could lead down to 5 years down the road. You have new contract managers, new people just saying, this is the way we've always done it. I have no clue why we do it this way. It was passed down to me 3 times. And I say this from a real world example because I inherited a conversation right now that is on this right now. So
Oh, yeah.
just trying to share that.
Very familiar.
Got some feels.
Very familiar to me as well.
got
Thank
in
you
my
all
feelings.
for joining us today. Thanks to our panelists for their wonderful insights. Have a great afternoon.